Good afternoon, all. Welcome to our final session. Today we'll be having a session taken by Rajagopal sir. We can start with sir's presentation and have discussion after that. So over to Sunil sir.
Thank you, Rajalakshmi. So today is the last session in the COVID series. So we will be discussing about communicating bad news, especially the end of life and bereavement support. So this session will be taken by Dr. Rajagopal, and so welcome, and it's over to you.
Seema was supposed to do this session. She has to her outpatient clinic, and therefore I am stepping in. The majority of the audience now are palliative care people. How many do you think, Raju, will be there, people who are actually treating COVID? I see that there were only 2 people in the group who were actively treating COVID, right? One is Professor Chandni and the other Dr. Suma. Okay. But many of us, if some of our fears come true, many of us may end up treating people with corona. Between the summer and government action, we seem to have avoided a peaking of the COVID so far, but we don't know what is in store. And it is possible that many of us may see people actually dying of COVID-19. And in these uncertain times, the better we are prepared to meet that crisis, the better, of course. Generally, in the general medical scene or among government activity, most of the discussions are centering around testing, avoiding the peak, flattening the curve, and that kind of thing. Very few people are talking about advanced COVID and how to manage it. I think we have to take the lead in preparing others because we could be moving towards a crisis there. The crisis could be that the breathlessness being one of the commonest causes of COVID-19 and pneumonia resulting in respiratory failure being so common. Global thinking is towards ventilator for the majority. And many people are trying to put together hastily assembled ventilators and so on, which I believe is an unrealistic proposition. So what we have talked about so far are triaging the patients so that those in whom ventilation will be inappropriate will be directed towards palliative care without going the aggressive life support way. So yesterday, Biju talked to us about the principles of communication. And as you know, Biju, when he does that, he does it really well. And many principles of what not to do and what to do were conveyed very well. Biju, particularly, I took in and cherished that idea of a smiley in the voice. When we are forced to communicate with this and many other items of personal protection, making do with what we have is so frightfully important. So I'm now going and building on what Biju said yesterday. and taking it to the end of life scenario. Raju, could you start sharing the screen for me? Okay. Now, this may this may seem an obvious statement, but if you give thought to it, this is not what the medical system attempts to do. Medical system attempts to cure the disease when possible, and even when it doesn't seem to be possible, keep on correcting biochemical abnormalities and organ dysfunction. The attempt is to maintain the circulation, maintain blood gases, maintain the serum sodium and potassium, even as the patient is dying. So, if it is an end-of-life situation, our primary focus is to keep the person comfortable. It is not to prolong life at all costs. On Monday, that was one of the points that I laid emphasis on. The primary duty of care of a doctor is to mitigate suffering. I quoted ICMR, and you will find the reference in the PowerPoint from day one. The primary duty of care of a healthcare provider is to mitigate suffering. It is to cure sometimes, relieve often, and to comfort always. And there exist no exceptions to this rule. If, when my time comes, as I am dying, your attention goes to my serum sodium and blood gases and not to how I feel, I believe you will be failing in your duty as a healthcare provider, as a doctor. So the patient's comfort in the context of end of life is the primary objective. And secondly, something that we do not give a lot of attention to ordinarily is the family's comfort. The family has been, especially in the context of COVID, where the family has had no time to come to terms, where a patient is taken away from them, shut in an isolation, and they don't even get to see the dead body. That's a cruel kind of parting with no closure, no opportunity to come to terms. And therefore, our health becomes all the more important. Now, a busy clinician like Dr. Suma or Dr. Chandni would be faced with a situation where the demands on their time are so many that where is the time for all this? So that's one of the things that we'll talk about. With limited time, what little we can do. And in the occasional patient, remember, all this is not only valid for the registered patient in your hospital. We are on at risk. It's about our loved ones also. So when you have a minute more than what you ordinarily have, what do you do with that time is one of the things that we will talk about. Yes. So we have been schooled into a system, as we said, where we are taught to look at diseases and body and chemistry. And when I ring up our ward, palliative care ward one evening or night and ask, hey, how is so and so? Our nurses will not be reeling out what an ordinary hospital nurse says. That they will be saying, his temperature is so much, his BP is so much, his pulse rate is so much. His blood counts have come, they are such and such. Instead, our nurses would mention that when necessary, but also focus on the person. And they may say, he was a bit restless this evening, but now he is comfortable. his daughter has come to visit and they are together now. And that would be the kind of approach that is necessary. We should be able to look at the suffering as an entity and identify the individual elements of suffering. Talking about palliative care, we at one time mentioned that these elements of suffering can be physical, psychological, social, including financial, and spiritual. We may not get around to looking after all of them, but what we can, we do. We will see how we can overcome these elements of suffering so that quality of life improves for the patient and for the family. That is one of the things that seldom happens in intensive care unit, majority of ICUs, is to communicate, is communication with the person. Usually, once somebody is in an ICU, it's a body there. And so many of my friends have heard this. I have a friend who is still living in Trivandrum, who had a stroke, couldn't communicate for 3 months. And he said the worst experience of those 3 months was nobody ever told him what had happened to him. Nobody told him, you have had a stroke, that's why we are unable to talk. And you are unable to talk. But doctors are hopeful of this, and this. Nobody talked to him. And for 3 months, because he couldn't ask anything, and he couldn't move his right arm, nobody gave him a pad and tried to get him to write with his left hand. He was in this anxiety for 3 months. The person may appear to be unconscious. But what's the problem in saying, Mr. So-and-so, I am going to turn you around so that I can feel your back? Mr. So-and-so, you are unable to speak, so I don't know whether you are in pain, but if you can blink once if you are in pain. We may try that. Even if he appears to be totally unconscious, there's no sense in, no reason why we should not communicate, because it is possible that somewhere deep inside he may be able to perceive something. We don't lose anything. And especially in this case where as we said earlier, the family suffering is horrendous. Just remember to think about the children. We have a patient here now who may not go back home alive. It is 3 weeks since they left home. Not COVID, of course, but it is possible that she may not be able to see her children again, and the children may not be able to see them. I am worried more about the children. We tried. Is it possible to get the children across? But they live across the state border. It's not going to be easy. But at least think about it. See if we can do anything about this. Those children are something like 12 and 10, something like that, at a very vulnerable age. Their emotional scars can cause lasting damage. A few words to help them to understand what's happening, to help them to cope, that would be so important. Next, please. So now coming to the specifics of COVID-19, where it is possible that we may end up seeing a lot of people with multiple comorbidities, the elders who have poor chance of survival, especially if it's a multi-organ dysfunction, inappropriate end-of-life care is not only wastage of resources, it's not only about blocking ventilators for which others can get back to life with, it's also about inflicting suffering on the person. Here is a person who is leaving this world without another chance to say goodbye to the loved ones. The least we can do is to give him some comfort and to convey to him that we care for you. We are here for you. We will do our best for you. Do you have a message for your family? Let me convey it to them. And I will bring you any message from your family. That's the least we can do. Instead of putting in that endotracheal tube and connecting him to a machine, which does not help the person or help the family. Yes. One of the obstacles that we may come across is the concern among the treating team, doctors, nurses, anybody, or the family, that withholding or withdrawing artificial life support is euthanasia. This happens particularly after a Supreme Court ruling of 2018, which unfortunately called withdrawal life support passive euthanasia. This is a misnomer. The Supreme Court was not taught by the experts who advised them about the scientific definition of euthanasia or what the word means. The ICMR document brought out in 2018, I would encourage everybody to open that link and look at the executive summary. It's a long document, true, but the first 5 or 6 pages would be worth reading because there is important information. And they highlight the point that euthanasia cannot be passive, because in euthanasia there is an intention to kill somebody with good intention, with the intention of relieving suffering, but it is still the intention to kill. Next, please. And withholding or withdrawing a potentially inappropriate treatment in a patient dying with a terminal illness cannot be construed as an intention to kill. That's what the ICMR says. In other words, allowing natural death is not the same as killing somebody. In euthanasia, there is an intention to kill. In withdrawal life support, it's an intention to allow natural death. That makes all the difference. So, when we talk about euthanasia, when we talk about withholding or withdrawal of life support, colleagues will come up with an issue. And within the treating team, there has to be an agreement. It's the responsibility of each one of us to make sure that our colleagues understand this. You shouldn't be suspected to be a killer. You are a compassionate doctor, allowing humane, natural death. Next, please. Some of you, all the palliative care people would be familiar with, and some of the others too. Dr. Elizabeth Kubler-Ross, a psychiatrist in USA who died in 2005, who came to me known as the death and dying lady, while she wanted to be called the life and living lady. She has did so much of work among the dying with whom nobody else had worked so much earlier. And she describes an individual's reactions to bad news like this. Now, why am I bringing this up? I'm bringing this up because we have to understand that your patient or the family member could be in one of any of these states. They could be in denial. This cannot be true. This cannot be happening. No, I am not dying. I am going to get better, I am sure. And the daughter saying, no way my mother will die now. It's not possible. She was all right last week. What are you saying? That denial. Also, we'll remember that they could be angry. And we all know this. Even last week, when a patient with COVID-19 died, a doctor was attacked. The anger is against COVID. It's against the God whom he feels deserted him. But it comes out against whoever is available. You all know this. When you are irritable, you pick up a quarrel with your spouse. Happens to all of us. You show your anger at the kids. You show your anger at whoever is vulnerable. And in this case, you, the doctor, are available. God is not available to shout at. You are there. This anger will be precipitated if we respond in anger. When somebody is angry and shouting at you, getting angry ourselves and shouting back is the sure way of escalating the issue. If instead you don't jump to justifications or anything like that immediately, you just sit down and listen. Make the person sit down. And then there may be a way of moving forward. Bargaining. Did our patient downstairs and the family spend a lot of time, a couple of years in bargaining? When the medical profession wanted oncology treatment, they went system hopping from Ayurveda to something. So here there may be a different kind of bargaining with God. God, save my mom, and I will do this, this, and this. I will go to this holy place. I will do this. I will give up that. I will shave my hair off. This is a reaction, but the bargaining may be with you. But, I will do anything that you want. I will pay you any amount. Please save immoral. Depression is another natural reaction. Feeling sad is normal. If there's a bad news, you feel sad. If you have misplaced and lost your mobile, you feel sad. You miss it. You may. This cannot be true. And when you feel the other pocket and hear and look around, you are in denial. And you feel sad. That's natural. But in some people, the depression can go to the extent of an illness. Now, this is something that we are all going to see all over the world. A lot of people are going to be dead with no time for the family to come to terms with. And because there has been no time to cope with, there's going to be a lot of clinical depression, or it's all inevitable. And according to Kubler-Ross, the final stage is acceptance. Okay, this has happened. Now what do we do about it? We have to understand that the family could be in various states. Several of them could be in several states, and we will have to customize our communication appropriately. Next, please. With that, I will go to I'll spend a few minutes about how to move with a difficult issue, a crucial conversation. You are going to tell a patient that the chances of survival are limited because you want him to take the right decision. Param, we have not met each other except over this medium since Monday. We are practically strangers. So if you are there as a patient in that situation, and I am coming to you and talking about end of life. That's certainly not going to be easy. Because for you to follow my advice, you need to have trust in me. And in that minute, how can I build that trust? Raju? If I don't look ferocious, look, this is going to be all the more tough with COVID because this thing is, there is a barrier, there is a distance. We are not even shaking hands. And the patient is there, possibly wearing a mask. I absolutely loved Biju's, I already mentioned that smiley in the voice, which is maybe all that we can do. But using that, I see that you are in a lot of suffering. I see that you are worried. Would you like to talk to me about it? And that helps to build a relationship. Somehow I have to communicate with my eyes and my voice that I care for you. Next, please. Yes, next. And I have to listen to what you may not say. If there is pain in your face, pain in your eyes, I have to say that. I see that you flinched when you were touched. You must be in pain. And acknowledging that helps to build a relationship, build a trusting relationship. Next, please. Next. Before I give you any information, I have to gather information. But I mean, if you were that patient and I asked you after that conveying of empathy and saying what I saw, I ask you, before giving any information, I ask you, what do you think is happening to you if you are able to talk? Or it may be with the family. We don't have a lot of time today to do several role plays. But if you were a family member of a patient and I asked, what do you think is happening to him?
I mean, I don't have the background of what I'm having right now, but is it about COVID or something? Are we talking?
COVID.
Yeah, so I could be just having fever or cough, and I have not gone out of the house at all. I'm very sure I have not come in contact with the person, although I've been hearing about it. So I would be kind of expecting that my test is negative, and there is no way I could have that disease.
So you see, for someone who is simply not ready to receive the news, giving it like a bombshell would be one good way of ensuring depression or an anger. So, Raju, not now, maybe later. It distracts me, that's why. I have to ask this question. I have to get to your feedback. And instead, you might have said, I've been anxious, doctor. Do I have COVID? Then I may suspect that the person may at least have thought of the possibility. I have to know this. I have to know where you are, your level of understanding before I move forward to give you any information. This is not only for COVID. This is for any clinical situation where we give bad news after finding out. It's not going to take necessarily 15 minutes. Maybe just a minute spent on it would still be worthwhile. Next. Close questions are not good in this. It has to be an open question which cannot be answered by yes or no, like one of these questions. Like one of these questions. What do you think might be the problem? What worries you? I see that you are looking a bit of in shock. Is that so? One of those questions could bring out information and tell me where you are at the moment. Next, please. And I have to understand not only what you know, what your feeling is about that situation. Whether you have given up completely already, whether you are ready to fight. I have to understand your perspective. Right? And at this time, particularly, we'll be ready for all these reactions. You may cry, maybe angry, maybe silent, and maybe express total despair. And silence doesn't mean that the silence will be forever. Very often the silence is only for about 10 seconds. And if we can afford to wait, that will be very good because then they bring out what is bottled up inside. Next, please. So, Param, one more question to you. Suppose you were the son of a patient with COVID, and you have no idea what you are going to hear. You are anxious. And suppose to find out what your thoughts are, I ask, tell me, you look anxious. How do you feel? What are you feeling at the moment? How do you respond to that, Varam?
Well, Structure, I'd probably say that I've heard a lot about this, and I'm very fearful at this moment what is going to happen. There is so much of talk about people not making it, hospitals not being able to look after people. So I'm very worried about which way my father or mother, let's say, is going.
So, this
I'll,
question, yes.
yeah, no, I'll fear for their well-being and life first of all immediately. Yeah.
When you give me that answer, you are making it easier for me because now I know that you are prepared to listen to bad news also. You have considered that possibility. Whereas if it need not be so easy, it
Absolutely.
can be easier, but it need not be. And if at this time the response is, he is going to get better. I have prayed and prayed and prayed. I know he's going to get better. Then now I know that I have a more tough job and I have to be careful how I lead the discussion forward. So I'll repeat at this stage, finding out the patient's level of knowledge and what the person feels about it is particularly important. And I am taking a lot of time describing this, but that need not usually take a lot of time. And a couple of minutes invested on finding this out can be very precious to lead our way forward. Next, please. At this point, I cannot withhold the information. There is pressure of time. It has to be conveyed. And it's so important to avoid jargon. We unknowingly will bring out the technical terms of lobar pneumonia and hypoxemia, etc. That has to be avoided. We will have to use plain language and say, I'm sorry to disappoint you, but I must tell you that unfortunately his condition seems to be turning for the worse. That was a warning shot. And suppose you say that, no, that cannot be happening. Doctor, please tell me he's going to be okay. You will do everything. You won't give up, will you? Please don't give up. Do everything. And that may be the time for me to convey the message. Certainly, let us continue to hope for the best. But very often, it's also good to be prepared for the worst. Continue. I hope your prayers will be answered, but it is also possible that things may not turn out the way you hope for. And therefore, I want you to be prepared for that. That's why we are having this conversation. Next, please. At some point, at this discussion, I hope we'll get to an agreement on problems and plans. So very often we have to accept partial support. We may end up agreeing with the family that we will not intubate and ventilate, but we'll continue the oxygen inhalation as long as the patient seems to do well on it. Partial support may have to be accepted while the family gets more time to think about it and discuss it, or if the patient for that matter. Now, at this point of time, let me take you back one step. If it is a patient with multiple comorbidities, an elderly man with whom you are having this conversation early, he's not dying yet, but we are bringing up this conversation. Let us certainly hope these medicines will help you and you will get better. But because it's better to be prepared, let me ask you, if things do not go the right way and your breathing becomes worse, what do you think should be what would you like us to do? I personally feel that giving artificial ventilation may not be useful. I personally feel that it may be better to continue all that we are doing and make you as comfortable as possible rather than take you to put you on a ventilator. If that is agreed on, very often we are able to. Very often people have thought about it. We sometimes assume that everybody is always clamoring for a ventilator. Very often people have thought about it and they may make clear their wish. Once we have agreed on a plan, I think we have to review the issue, clarify the understanding, and then close the conversation. I may think that I have conveyed my message very well, and you all would have the experience. You may have told the family, look, such and such are the issues, and the person is likely to die in the near future. And all this you think you have conveyed, and finally, so what did you understand from the conversation? And they may say, so he's going to be okay, isn't he, doctor? And that kind of misunderstanding may come out of their own optimism and poor understanding of they're simply not being able to grasp what we have been saying. So it's important to review what has been said and clarify understanding. Next, please. And always try to avoid abruptness, just getting up and running away. Sometimes it becomes absolutely essential in a busy place, but try to avoid that. After the review, I am sure you will have more questions later. Please call our clinic, and maybe when necessary, we can arrange another telephone conversation at least. It's good if we can leave the door open to talk again. That tells the family that we are open to communication. Next. If the patient is already on a ventilator and we are talking about withdrawing this, as far as possible, start the discussion early so that we allow the family time for discussion and arriving at a decision within their own minds. And as I said, accept decisions or partial support. Never bring in at this stage the question of money. If you say that if you keep him in the ICU, it is going to cost so much every day, the family may well think, well, my dad's life is worth more than that. What are you saying? And that kind of guilt in the family will happen to some extent, but we should try to reinforce that. And one final important message, never say there is nothing more to be done. That's not what we are doing. Even if we are withdrawing the ventilator, we are not doing nothing. Instead, we will say, We will continue to do everything for your dad, for his welfare. We will do everything to make him comfortable. That should be our message. And before I conclude, as I said, there are going to be a lot of families who will be bereaved by the time the pandemic is over. As I said, they wouldn't have had time to grieve, to come to terms with this. There's going to be a lot of people in grief. And grieving is natural and necessary for us to get on with life. If we have lost a loved one, we need to go through the grief so that healing takes place. But unfortunately, in this sort of context, often grief can become pathological. That means going out of the person's emotional ability to cope, going to a state of disease like clinical depression, maybe causing suicidal ideation, or somebody continuing to be in grief for sometimes for years and not able to get back to a reasonable quality of life, even after a year or two. Ordinarily, when somebody has lost a loved one, the grief is forever. It never stops. But usually, in the majority of cases, in about 6 to 9 months, somehow people get back to life and continue to live a life that's a bit close to what their life was, but not necessarily. And particularly the anger, which often is against the medical profession, will keep burning inside, and that can be a huge problem unless there has been opportunity to communicate, to get over the anger, etc. Often panic attacks continue. You all have read about what happens to victims of kidnapping or victims of torture. It can be a bit like that for the families. We expect that there may be panic attacks and people waking up in fear in the middle of the night. And often people will carry guilt. Whatever they have done, they'll feel guilty about something else. I wish I had done that. I wish I had done this. That's also something for us to listen to and help them to cope. Yes. And finally, we cannot get it right all the time. We are only human beings. None of us is God. We have our limitations. And the issue presents numerous limitations. There is no time. There are so many problems, and there is no time for coping. You and I have to come to terms with the fact that we cannot solve every problem. There will be limitations. There will be failures in our attempted acts, and that is something we have to come to terms right now. Saying that telling ourselves that the weeks and months to follow, there are going to be issues that we will not be able to solve. We will have to be content being able to do our best. Thank you very much. I am stopping there. There are several people here who teach communication. We teach communication in other contexts. Moira, you have done it all over the world. In how many countries? Oh my God. And Param, you have been teaching communication, particularly in the context of chronic neurological diseases. So many palliative care people have been teaching communication skills. But here we come across an issue which will be very different in intensity and brevity of time. Please share your thoughts or ask your questions. Dr. Murthy's hand had already gone up.
Our small hospital in a mandal headquarters is established about 73 years back. I am there in the hospital since 52 years. many of the people in and around 2 lakhs population are born in our hospital before government hospital got established. And many of the people find it as a gateway for heaven from our hospitals. The people that are sick, people who have gone to 5-star hospitals, once they are coming out of it, we discuss with them. We have a group meeting with the family. We call for all the family members, whichever is possible to get to the people. We admit them. We tell them, this is the situation. You have already had treatment. Now it is almost final. Whatever you would like to speak, speak. But we don't have, we have an ventilator, but we don't want to resort to it. Oxygen will give you. So this is the end of the stage. You want 1 or 2 days to be. Every man, usually every man or woman would like to die in the place of their own home, the last breath. So when there's time, you will say 2 or 3 days, time is there. Your BP is okay, it's going to fall down, it's falling down.
Murthy, you'll have to be brief. Please be brief with your points because I unfortunately overran time.
Family discussions and we send them home not too happily. Some problems they have. By the side of our own house, there is sub-registrar's office, bills, all these things will be done. We don't face much problems because we discuss with all the family members.
Dr. Murthy, thank you very much. That's very powerful and very important. But here in the context of COVID, very often we will have the situation where this luxury is not available anymore. They will be in isolation. They'll be separate from the family, and the family may not even be able to see the body, view the body, and have time with the body. That's a difficult situation. For 52 years, you have managed it so beautifully, and now we come across a situation which is wild and different.
Can I?
Param?
Carry on.
Yes, Param.
Okay. Can we mute the mics? Yeah. So just a few comments. So thank you very much for that comprehensive thing. What I was thinking, some things you already said regarding the suddenness. So this is different from a chronic illness, and over information may be an issue than under information because of so much information going on. But the point which worries me in this situation is that how it is so unique for COVID is that in other chronic illnesses or even acute illnesses, it is a person brain dead or going to be brain dead and we withdraw life support. Now here, instead of being just a doctor, we may have to play like a legal judge to choose who goes and who goes off. So in ideal circumstances, a patient who may have gone on a ventilator, we may not send with the back of thought that somebody might do better on that. So this dilemma is very, very unique to this humanitarian crisis kind of a thing where resources are limited. So dealing with this with the family or the patient may be very, very more challenging than what we are used to.
Absolutely, absolutely, I agree. Param, but if I may bring a parallel, here it's like somebody coming with a road traffic accident and serious brain injury, not brain death, not the brain death situation, where there is still injury, and you helping the family to take a decision, maybe regarding organ transplantation, difficult decisions like that. So that may be a closer parallel, but yes, the suddenness and the limited time are important things. But when we give them, when we understand where they are and help them, often we can avoid the major traumatic disorders that may follow in the family and make the ending as comfortable for the person as possible. The person who is still conscious and has to face the fact that he may be dying will have this absolute yearning to see his family also, to say a final goodbye. That's not possible. And there, the only thing we are able to offer them is our care and our love. Saying that I'm sorry that you are not able to see your family again. I wish we could help, we care for you, we will do the best for you. It's the one message that we can give at that point of time. Narendra?
Yeah. Sir, let me be very specific. The one point is, we need to communicate to the people in a single voice, saying that we need to do this and we need not to do this. Already the government is doing that. But as an NGOs, we need to fix up flexes. We need to educate more on these things, and awareness and education is the only thing that can save us from this pandemic. Or else, as it is, you and everybody knows that there is no treatment. And taking an example of Andhra Pradesh, having 700 etc. of this whatever this ventilators cannot save some crores of people. So let's build up a network with all the people, and let's propagate a message. You can put up your ECHO, you can put up your Pallium, you can put up your me and myself, I prefer lines. We can prepare something else. The EC materials,
Narendra, please be brief. Please brief.
transfer to everybody, and everybody, it should be acceptable. Thank you.
Thank you. Absolutely. The more the information that is for more thinking about this that happens, the better. But unfortunately, right at the moment, the media, the government, everybody is harping on the testing and flattening the curve, and nobody is yet able to think about end of life or decent end of life care. There are several chat questions. Dr. Siddharth Sharma says passive euthanasia is legal in India. Dr. Siddhartha, let me bring back my point that the Supreme Court allowed withholding and withdrawing life support, and unfortunately called it passive euthanasia. The term is a misnomer. As the scientific body, Indian Council of Medical Research, pointed out later, what the Supreme Court permits is withholding and withdrawing life support, and it was wrong to call it passive euthanasia. Withholding and withdrawing, as you correctly said, is legal, but the guidelines put in are too complicated. In the 2 years, almost exactly 2 years and 3 weeks, 2 years and 1 month, since the Supreme Court judgment of 2018, not even one person has been withdrawn in the country going through that process, because those processes are too complicated. So unfortunately, the Parliament has not enacted a law. The Supreme Court judgment said that the judgment will remain valid till there is a law on this matter. Again, a task force of the ICMR, including a Supreme Court judge and a professor of law, opines that all that legal procedures need to be valid only where there is a controversy. If the treating doctors are agreed on the duty of care, and if the patient and family are agreeable, the legal procedures need not come in. But I agree that there is a question mark still left there. Can you scroll up before the other chats? What is on the top?
Respected sir.
Wait, one second. Sorry, who is speaking? Anil, 1 second. Narendra, 1 second. Moira's comments to everyone. US health staff attaching laminated photo of them smiling to their uniform. We have to be careful about infection control. But still an innovative way to add to the smile in a voice from Dr. Biju. And also we can see how we can support frontline staff as well as direct support to patients, especially those of us who have experienced this area of communication and writing bad news. What we are attempting to do, we must, you all must give your feedback so that our subsequent courses can be modified precisely to offer that better support to the frontline staff that Moira is recommending. And certainly supporting each other. Yes, the staff are likely to be at great stress and strain, and there are going to be family pressures. It's going to be a huge problem. And another role for the healthcare worker present at the death of the patient is calling and telling the family that I say something like, I was there with him. I'm sorry that you are not able to be with him, but I was there with him and we made it as comfortable for him as possible. Thank you, Vidya. What was that? No, that was from Param. Absolutely. Thank you very much, Param. That's so important. Okay. Sorry, Narendra, you wanted to say something else?
Yes, sir.
Unfortunately, that might be the last
Exactly
question.
what I wanted to speak is, we need to communicate to the common public. Already educated people will be knowing by their TVs and other multimedia material. We need to educate and aware them regarding all these complications in their own language. So, for example, we need to create something. We need to formulate a basic, truthful information, which will be finalized by the ICMR or any other medical council.
Thank you, Narendra.
By that
very
way,
good suggestion. Sunil,
we can do it because I can print it 1,000 pamphlets, 2,000, 5,000 pamphlets. I can print, but I will not have. I don't need.
Sunil, I am sorry that the time is up. Can you come and close the session?
We are sorry, we have to finish end this session now because it's 4 o'clock now. Before ending this session, I would like to ask Dr. Chandini and those who are directly involved in COVID patient care, is there anything that we have modified this series of COVID sessions? Dr. Chandni, are you there?
Yeah. Can you hear me?
Yes, madam.
Yeah, it is fine. But only thing, suppose people who are coming from non-palliative setting, they may not be familiar with most of these drugs and doses because we don't usually prescribe it, to be frank. Okay. So those things you need to highlight, especially those things like use of morphine in patients on ventilator. And I told that disturbing cough when a person talks to us about how we should address. And lastly, one thing that might miss in this series is we never address the family. Okay, so maybe we can just mention about that also. Over a phone, at least we should tell that the person's condition is this. That will be very relieving because patient may not on ventilator or paralyzed may not be knowing, but the family will be very anxious. So that part also we have to address, which usually do not happen in these situations. And if the number is less, we can address. Otherwise, it is fine, sir. I really enjoyed this and I've learned a lot from this training. But if we could get the summary so that we could refresh or see again and again if there is something we need to look back. So that will also be very useful, sir.
Yeah, yeah.
Thank you,
Yes,
sir.
we will be sending you the summaries, including the ebook, so that
But
you have.
unfortunately, you people thinking that we are speaking about only palliative people, that we are not talking about palliative people, we are talking about the general population, even though we are treating the palliative people. Unfortunately, tomorrow, let you come to a discussion regarding the triage. If are the palliative persons will come into the triage or not? If it are 35 persons who is a young person is going to die of ARDS, and if another person with a palliative care who is with tertiary care or stage 3 diagnosis of cancer, who do you want to intubate? Kindly answer me this question. Thank you.
Another point is for Rajagopal sir, we need to address this issue, sir. Now I am in the emergency medicine, so palliative care in acute medicine.
Yes,
Yes.
absolutely,
So in
ma'am.
fact,
That's
I was about,
yeah,
in fact, I was
let's,
about to come to you to help us in this regard also. But this is COVID was in between, it came, and so we had an opportunity to interact. That's good, sir. Thank you.
Yes, yes, certainly indeed. Integration of palliative care with emergency rooms and intensive care units is a fast-growing field. That doesn't mean that a palliative care person always is there physically, but every intensivist has learned the fundamentals, and a palliative care specialist is called in when necessary. And coming back to Narendra's question, yes, that's one of the issues that we are going to face. Currently, all the emphasis is on patients with COVID-19. What about all those people who are going on ventilators anyway? And therefore, this is not only about COVID-19, as Narendra points out, this is about a lot of people. Now, the one solution that we have recommended to the government of Kerala, which appears to be finding favor with them, that the triage, that's not our invention or anything, that's international, triage team should be different from the clinical team. Narendra is treating a patient, and Narendra shouldn't have to decide which of these two should come in. Because there will be so many with COVID, the triage team is an independent team to be consulted with by an ethical committee if necessary, and they may have to take that difficult decisions. But I know that we will have to reorganize the whole course. Do please send your feedback. That's because we need to go ahead with the course at a much larger scale. And I know that the allocation of time for the individual topics was not quite rational now that we look back. Would you agree that this aspect of yesterday's and today's communication sessions should have got
So
more
let us
time?
do with the triage tomorrow, if possible.
Raju, Sunil, if the course officially, this course is over, and because you have other things to do immediately, but let us come back to this group and do a final wind-up session if that's possible at all next week. One session for the whole team where we take out all the questions that are still pending, deal with all of them, deal with triage, and maybe particularly you, Moira, a few people experienced with a little more time spent on communication. I'm sure that will be very good. Narendra, we'll try our best to organize it, not tomorrow, but someday next week itself, we'll try to organize that. Thank you very much. Moira, you are training all your ICU physicians in palliative care in Uganda. Well done. Great, fantastic. That's the way forward. Yes. And integration of palliative care into all healthcare, as recommended by World Health Assembly is the answer. Sunita and Chitra and the rest of the team, congratulations on putting together the electronic handbook,
So
e-handbook.
can I say something, sir?
Yes.
So the triage is included in the electronic handbook. It will be ready sort of by the evening today, or most probably tomorrow. So Smriti has agreed to share with all the members of the group. It's an algorithm. And I'm sure sir said we'll organize a class again next week. So please go through that before that, and then we can discuss your questions when we organize the class.
So this e-book that Sunita and team, that was a phenomenal work, Sunita. I don't know how you all put it together in such a short time.
Thank you,
And
sir.
that's phenomenal. Moira, thanks for your support. I mean, you were always holding people's hands and supporting. This book will reach you tomorrow. And Narendra, some of your questions will be answered there. And we'll try to do this revision session to fill up any gaps that we have left behind. And I apologize that we have already kept you so late after the 4 o'clock deadline. Thank you very much for your patience. Sunil, have you concluded? Okay, thank you for participating. And I really think you have contributed so much just by pointing out the issues, by pointing out gaps. Everybody, please make suggestions about how we can reorganize the next course to be more effective, including the time duration. Thank you very much.